I'm supposed to talk to you today about hepatitis E during pregnancy. But I believe there has not been any other talk on hepatitis E, so I'll take the first few minutes to talk about hepatitis E in general and then move on to hepatitis E in pregnancy. So hepatitis E is a disease caused by infection with a virus, which is a small sized virus. The virions are icosahedral, and these exist in two forms. Most viruses are either enveloped or non-enveloped, but hepatitis C virus exists in both the forms. And this virus is excreted in the stool of those who are infected, and then it enters the body of the next host by the oral route, so the so-called fecal-oral transmission. And there are at least 4 different genotypes, and that becomes important when we talk of pregnancy. So this is a somewhat old slide, but this is somewhere where I was involved. We try to look at the epidemiology of hepatitis C for global burden of disease study. And this slide shows the parts of the world where over a 27 or 28-year-old period from 1980 to 2007, there had been outbreaks of hepatitis E. And the color or the depth of redness shows the size of the outbreak, and you can see outbreaks were seen in most of the tropical countries, and gray areas are those where there are no reports. So there could either be no disease, no outbreaks there, or those have not been reported. And so it causes outbreaks. Second thing, and some of those outbreaks can be fairly large, as you see in India, China, and some Central Asian countries, and in Africa, there have been outbreaks affecting several thousand people. In addition, it also causes hepatitis, which is not in the form of outbreaks, forming a part of the usual acute viral hepatitis that we see. And here the depth of red color shows the proportion of acute sporadic hepatitis that is caused by hepatitis C virus, with red colors indicating a larger proportion being caused by hepatitis E virus. The virus has 4 genotypes. Of these, genotype 1 and 2 are mainly seen in Asia and Africa, and there have been some reports, 2 reports in 1980s of outbreaks in Mexico, and they were small. So if you see these areas that are shown here in yellow and in this greenish, dirty, bluish color, and also these areas, these are the areas where there is genotype 1 or 2 virus seen, and that is what causes outbreaks. Those viruses affect only humans, whereas in the parts that you see the brownish color, that is genotype 3, and that blue on the side is genotype 4. Genotype 3 and 4 viruses mainly are circulating all the time in animals and occasionally cause human infection. So they are different viruses. So genotype 1 and 2 virus are seen in countries where the infection is hyperendemic. It is infection that can, the reservoir is in humans because this virus cannot affect animals, and this leads to outbreaks which can be of different sizes. It also leads to sporadic hepatitis. It is transmitted by water or sometimes possibly through food, mainly affects young people, and there is a relationship with pregnancy. That is our main discussion today. On the other hand, genotype 3 and 4 are very common in animals but does not cause disease in animals. Occasionally, it causes infection in humans, mainly among elderly. This is seen in industrialized countries of North America, of Europe, and that does not seem to have an association with pregnancy. So if I were to tell you about hepatitis C in general, so this is where my association with hepatitis E began, with an outbreak in Kanpur, where there were nearly 80,000 cases. But the interesting thing was that there were 48 deaths, and of them, nearly 1/4 were pregnant women. So that showed that pregnant women are more likely to die than non-pregnant women during an outbreak. And if you look at literature, before that, there had been an outbreak in Kashmir, which had been investigated, and they found that when they did a survey in the field, of the nearly 4,000 men, hepatitis was present in only 2.8% of men and about 2.1% of non-pregnant women. But in the surveyed area among the pregnant women, the history of jaundice was much more common, indicating that when a waterborne outbreak occurs, pregnant women are more likely to be affected. Not only are they more likely to be affected, that is, they have a higher attack rate, but in them, complicated disease, that is acute liver failure, is infrequent among men and non-pregnant women, but is much more common among pregnant women. Also, there is an association with higher mortality. So 15 to 25% of these pregnant women who have hepatitis die. There is poorer fetal outcomes. So there is more maturity, and there is more fetal death. And these complications are much more common when infection occurs in or disease occurs in second and third trimester rather than in the first trimester. So if we look at this, if we look at the left box as a group of men or of non-pregnant women, and on the right, the box represents a group of pregnant women, infection, whether it occurs more or not, we don't know, but possibly is equally common in both. But among those who have infection, disease, shown here with a yellow circle, is much more common among pregnant women than among non-pregnant women and men. Among them, those who develop acute liver failure is also much more common among pregnant women, and because about 2/3 of them die, deaths are much more common among pregnant women with hepatitis C than among non-pregnant people. This association has not been observed with genotype 3 and 4 disease. Whether it's a difference in the virus or something else, we don't know. It's also possible that genotype 3 and 4 diseases are generally, infection is seen mainly at older age, at which age pregnancy is infrequent, at least in those populations. And also that disease is seen much more among immunosuppressed people, and they are not the people who get pregnant. Why this disease occurs more in pregnancy, or why is it more severe in pregnancy, we don't know. It could be because of differences in hormonal situation, in immune differences. Some people have talked about that the virus multiplies in the placenta, but each of these remains unclear, and I would say we really do not know as of today why this happens. What does one do in them? Really, we don't have any specific antiviral that one can use in pregnant women. One needs to admit them. One needs to avoid other drugs that are hepatotoxic and manage liver failure as is usual with other patients with liver failure. Yes, if they deliver, one needs to be cautious because of liver injury, they will have coagulation disturbance. There is a higher risk of postpartum hemorrhage. So one needs to give them drugs that will cause the uterus to contract so that bleeding would be prevented. For the baby, one has to watch the baby carefully. Sometimes they are preterm, so you have to do the usual preterm care. You have to watch them for hypothermia, hypoxia, and hypoglycemia, which have been found to be common. Some people have talked about whether we should induce premature delivery. The role of that remains unclear. There is a vaccine, and I think I'll talk about this much more when I come back for the next talk, so I'll skip that here. So how can we prevent severe disease in pregnancy? Sorry, this is the vaccine part. So the messages I have for you is the risk of disease and serious disease among men and non-pregnant women is similar. So it does not change by gender, but in pregnant women, there is a higher risk of serious disease and death, primarily when the infecting virus is genotype 1 or 2. There is a vaccine available, and whether that can be used, I'll talk about that in the next talk. With that, if there are any questions, I can take those up, or I can take those at the end of the session as the organizers please. Thank you.